the last meeting of the Intermediate Strategies Work Group. And what we hope to do today is I'm hoping that we can go through the individual market and the Medicare ideas relatively quickly so we can be certain to spend time on the other three ideas, which we really haven't had much of a chance to discuss, and work through those. And then we have one other agenda item, which is talking about reporting to the task force. So that is our agenda. And Sarah, I'm going to turn it over to you. And why don't we go through the Medicare example?
Yeah, great. Yeah, Laurel, just flip ahead. So you can go to the next slide. So the way that we've structured the discussion here, the point is just to, you know, I know that you all talked about this pretty extensively at the last meeting. So just a really quick reminder, and then highlight what was added or clarified. Well, first of all, what the primary goals are, what was added and clarified, and then focus on the potential outstanding questions, and if there's any other discussion. So John, I'm happy to do these, or John, if you want to, it's up to you.
No, why don't you do them? I've looked at them. I'm good with all of these slides.
Okay, great. So just to remind everybody, this idea is to create a state-run Medicare Advantage plan. It would be the only MA plan in the state, and it would basically be testing out single payer in the Medicare Advantage market. It would decrease cost sharing for low and middle income folks, keeping some premiums and cost sharing for higher income as a way of getting revenue, and there would be a change to the benefit package, primarily to mental health, and that this benefit expansion would be allowed basically under the cost savings that would be generated under this model. So that's a very, sort of high-level bullet version of the concept. Next slide. So at the last meeting, there was some conversation I think Ed really brought up around wanting to get clear about what are the primary goals with all of these concepts. So we've tried to frame it that way. And so for this one, I think that there were two primary goals identified. The first was to be able to pilot single payer. So be able to test out various elements of single payer specific to the Medicare Advantage market. And the second goal would be to strengthen Medicare Advantage coverage, both from an affordability standpoint for lower and middle income folks, and from a benefits standpoint as far as expanded behavioral health coverage. Next slide. So at the last meeting, there was a lot of discussion about this idea. And so there were a few things that were clarified or edited, which, one of which being that this would be the only Medicare Advantage plan in the state. So this would be it, the only game in town. There had been some discussion potentially about maybe trying to extend this to younger ages. And while I think there was a lot of interest in that, folks felt at this point that would just make things more complicated than perhaps they could be at this point. So to take out that and just have this be for 65 and over. That there was talk about the benefit package with the mental health. I think there had been questions before about what a more comprehensive benefit package might be. And so I think what was clarified was that it would primarily be behavioral health focused. And then the last piece, that traditional Medicare would still exist. And so the enrollees could purchase supplemental coverage. That the primary shift here is that the state would be running the only Medicare Advantage plan. Anything that anyone wants, or John especially, or anybody wants to add to any of these bullets, or what has been said so far? Chuck?
Yeah, so this may be getting too far in the weeds for this stage, but so if someone's on traditional Medicare with supplemental plans and they chose that for the reasons for good reasons, if they wanted to go on to, I mean, people do that in case there's pre-existing conditions. That's one of the reasons they don't go to Medicare Advantage. And so I'm just sort of wondering if they switch to Medicare Advantage to try this new Oregon Medicare Advantage and then switch back, would they be caught in that pre-existing condition situation, or is that too far in the weeds at this point?
Well, I think that's an issue that would have to be
Worked
sorted
out.
out
Yeah,
from
okay.
a selection point of view. And a lot of it would be, would Medicare allow that? I don't know, I mean,
Right, so-
definitely, like there is now, you'd have to have open enrollment, or, months where people could switch back and forth if they wanted to.
Yeah, I think there isn't any real likelihood that you could prevent the annual open enrollment that occurs now. And that, Medicare Advantage typically enrolls because it is attractive to certain people. There might be, you're referring maybe to an adverse selection problem, where people might shift in one direction or another due to an adverse selection. And frankly, if they moved into Medicare Advantage for that reason, it could be financially challenging to the state to operate it. That would be sort of a question about whether you did encounter some movement in the other direction, Chuck, movement toward the Medicare Advantage that had a high claims experience because they could theoretically get all the providers in the state. And so there might be very little downside, whereas the current Medicare Advantage plans have limited provider networks and so forth. And that's often the reason people deselect from Medicare Advantage, and that might be gone away.
Right.
Maybe that's what you're referring to, but I think it would be annual. I don't think there's any way to get out of, as long as it's a Medicare Advantage plan, it would be subject to the rules Medicare sets up for Medicare Advantage, which is enrolling in and out of it on an annual basis.
Yeah. I mean, Chuck, Chad makes a good point. I would assume that we would structure this as all providers are in. That's what 770 says. All providers are in. So
Right.
You wouldn't have to like for Kaiser folks. I mean, I'm in Kaiser, but sometimes I worry a little bit about their specialty services, and it's a risk I'm taking. Here, actually, it would be hopefully everybody in the state would be in the Advantage plan. So,
John, would that mean we'd have to pass legislation to make that happen?
it's possible. It's possible, Bruce. Well, and I would assume that at least everybody who's in it would have to be participating in Medicare. I mean, there's 2 or 3%, I think, of physicians who don't participate in Medicare, right?
A little higher.
Yeah, and so I think we would be saying they would still be out. If they're not willing to agree to participate in Medicare, they're still out. But
John, everybody that participates in Medicare is not in any individual Medicare Advantage plan. And so what you're saying is that would be a condition of the plan, is that all Medicare providers in the state would be participants.
And in fact, we might even be pressed by single payer advocates because I don't know what the status is of naturopaths, chiropractors, acupuncturists, in terms of Medicare. I think they're also in Medicare, but I don't know.
Well, I am not even sure. This is a regulatory question. Medicare Advantage is a waiving of your Medicare rights.
Right.
And so I'm not really even sure exactly if a provider needs to be a Medicare provider to be participating in the Medicare Advantage plan, because it's done through a HMO typically. And so I don't know exactly how that works.
Yeah, I'm not sure
Yeah.
either.
Yeah, I guess,
Deborah, were you trying to chime in?
Sorry.
Yeah, but mine isn't along this linear conversation. So I think if this needs to be continued to a natural end, I'll wait until, the dialogue here is finished.
If I could say, Chad, I'm pretty sure that Medicare would require that, because they would not want out-of-state folks who are traveling into Oregon and they get sick to have some warning, hey, don't get sick in Oregon, because there's a bunch of people there who don't have to participate in Medicare, and you'll be open season on you. We'll have to check, but I bet, and we would certainly want to say we would want everybody to participate in Medicare, because we would hope that Medicare folks traveling to other states who are our members would be able to access the Medicare system. Follow me?
Well, they would have to be, because the Medicare Advantage plan by regulation has to operate for out of area coverage. So at least for emergencies.
Yeah.
This would have to follow all the rules of the Medicare Advantage plan.
Yeah.
yeah, so this has been great, man. I think there's a whole bunch of implementation issues that'll have to get dealt with.
Yeah.
So, right. Yeah. Okay.
So I had a question about, for sure, I think this would require state legislation. I'd be surprised if it didn't. But I'm also curious whether a waiver is required in order to make it happen. Somebody mentioned a state that's already doing this, and I guess that staff could learn what's required in order to do this.
In Medicare, it's actually, the term of art isn't a waiver. There are Medicare demonstrations.
I see.
And what this would be a Medicare demonstration.
I see. Okay.
The state would ask CMS to have a Medicare demonstration to do X, Y, Z.
I'd like to contribute a little more background that won't clarify anything. Medicare Advantage plans cost the government more money, about 15% more, and they have the reverse of adverse selection. That is, Medicare Advantage plans can pick and choose who they sell to under what conditions. This suggests that if this group comes up with a Medicare Advantage plan equivalent, it wouldn't have to worry about adverse selection, because it would be taking people who would usually be on traditional Medicare. And Medicare Advantage has demonstrated that it's cheaper for all around for the more adverse people in traditional Medicare to get care than it is for the healthier people to get care through Medicare Advantage. All of which is to say, it would be probably easier than we think to come up with a state-sanctioned Medicare Advantage plan, even one that offered more benefits than traditional Medicare. We should anticipate more than simple pushback, as every insurance company and healthcare plan in Oregon that currently offers a Medicare Advantage plan being pushed out of business. They will find a way to make this plan difficult.
Well, that's true. But then, of course, this is all about an intermediate strategy to a single payer, which would also do the same, right?
Yeah, no, Sam, you are absolutely right. There would be a bunch of interesting selection things going on, since folks could still opt into do the supplementary market. This is right now one of the most profitable lines of business to be in. And in one of my papers, I gave a link to a Kaiser summary as of October 2020 that had the profitability of multiple different lines of health insurance, and one of the most profitable was Medicare Advantage. There are 40 to 50 Medicare Advantage plans in the state. No, this would require quite the successful argument. The legislature would need to be serious about really testing the idea of a single payer, and in all likelihood, we would need to be able to get at least significant portions of the delivery system to favor this. But I am sure that a number of the insurers would oppose this to the end. They would see this as the single payers are now landing on the beach, and do everything they could to defeat this. And that might include some of the CCOs. The CCOs do own, I was surfing a bit, and Summit Medicare Advantage plans in Eastern Oregon are owned by MODA and the Eastern Oregon CCO. So I'm sure they would not welcome this.
And in Central Oregon, it's part and parcel, not ownership, but certainly very tightly connected with Pacific Source.
Right.
It's like that in many parts of the state.
Yeah. So I think just surfacing this will tell us a lot about who might be willing to talk to us, and who might, there's no way we would ever let one breath of this get to a legislator and think that we wouldn't do everything to beat it.
Can we go to Deborah, who was patient and had a comment, I think, earlier?
Yeah, no, this has been really interesting. So serves me for not being here all the time. I was just going back to the initial piece where the expansion to younger folks was eliminated, and maybe some of this is just my own bias since I was hoping to get in. But my thought is that, it would expand the risk pool, right? You get healthier, younger folks like me, young old folks like me in to sort of offset, some of those additional risk factors and expense at the upper end. And so I guess what I heard was that it would be too complicated. Does the savings and the benefit of expanding the risk pool not outweigh whatever complications of bringing these new folks online with the product?
Well,
Deborah, I believe that to change the age of traditional Medicare would require federal law change, if not approval. I believe that this plan is valuable. It is definitely worth the effort to explore. If Oregon created its state-sponsored, state-administered Medicare Advantage plan and got everybody in Medicare, it would become Oregon's largest single-payer, single-benefit system. It would be a remarkably cohesive kind of plan to run. You'd have 15% of the population with the same benefits, the same providers, the same insurance forms, and maybe even the same formulary. I don't know what the federal law is on Medicare about preventing Medicaid Advantage plans from negotiating drug prices. If that is true, that if Oregon forms a Medicare Advantage plan we can legally negotiate prices, that the probability that we can deliver better benefits at lower cost at least comparable provider reimbursement are high, and it's worth the trouble to find out.
So when you say federal law change, would that not fit under the demonstration definition that Bruce just outlined, or would this, or you think it's something above and beyond the demonstration project?
I can tell you immediately, Deborah, I don't know.
Okay.
Go to Chad. Chad, you're on mute.
Hear you.
All right. I think what we're talking about here is if we presume that OHA is going to be the manager of the product, and let's assume that, I think that's been discussed, then what we're talking about is OHA currently manages the risk on behalf of the Medicaid recipients right now. And we're talking about an expansion of their managed care role, if you will, into the Medicare Advantage market. And theoretically, at some point in time, OHA could expand further and offer another statewide insurance product to the people under the age of 65. So, Deborah, I don't think this really precludes that transition. It's just sort of expansion of their training wheels into a broader market. The other thing I wanted to respond to was that Sam, Medicare Advantage will always be an optional thing for a Medicare recipient. And the likelihood may be that the growth of Medicare Advantage, that it grows, but it's never going to be all of the Medicare recipients, nor will the feds ever permit a Medicare Advantage plan to operate in the state at the exclusion of traditional Medicare.
Thank you for that. The only other piece was, again, I hear Cheryl in my ears, like around the mental health. Like, what kind of considerations have we had to make sure that whatever our ideas of what needs to be built into this, which needs to be managed further up the road, is addressing the concerns of the folks who are closest to the folks who would be using the majority of their services?
We had talked about that, and I think one of the pieces, it has been to be clear that it wouldn't be the same as the current Medicare benefit, but that it would be expanded to include behavioral health.
You could theoretically take all of the yield and put it back into benefits. And so you could expand it in not only in mental health, but you could expand it into other provider groups, acupuncture, other things that are not currently provided as well.
That is the what we would really be testing. Can a single payer take, all of the profits that are now going to an insurance carrier, reinvest it in the population, decrease cost sharing, decrease Part B premiums for lower middle income folks. You return all of those benefits. Deborah, I really wanted to get rid of the under 65 stuff because as a couple of colleagues not on the task force told me, who saw this idea, you're now opening up multiple fronts when you go under 65. Employers are affected. It's just much more ambitious, much more complicated. And if you just started with a genuine test in one significant market, which is Medicare, of a single payer, that would be, as Sam said, pretty significant, pretty incredible, potentially. Now realize.
Yeah, I don't disagree with that, but they're never going to be on board. Like, whether we do it now or do it 10 years from now, they've got
Right.
profit motive there. And we can, baby step into it, or we can just dump in the deep end. I think the reaction is going to be the same. So I just want to posit that.
Yeah.
And I would just say none of this is set in stone and can evolve as thinking evolves, et cetera. I think it's the general concept, and where and how the eligibility is around the edges can certainly change.
And am I clear that we are proposing that OHA operate this?
I think that it's a reasonable assumption, Chad, because everything that we would want our new organization to do, the OHA is already doing.
Yeah.
And there may be some value in, for example, drug purchasing. If the same organization is purchasing drugs for the same formulary for both Medicare Advantage and Medicaid.
Which
Thank
I
you.
believe is one of our ideas coming up, because currently the state doesn't bulk purchase for Medicaid.
By the way, to answer that question, Sam, you raised earlier, these Medicare Advantage plans do, I'm almost certain, purchase and drugs and have drug arrangements as they have arrangements with the providers. They're really, you opt out of Medicare, and you opt into the HMO, and then they cut their deals.
And in Medicaid, Sam, each CCO does its own purchasing. There is not statewide purchasing under Medicaid.
That sounds like an easy remedy we could propose.
It's an interesting option, actually.
Yep.
Oh, so the last part of this was just identifying questions that, you know, would still need to be answered in the future, things that could go in the report. Laurel, if you want to go up a few slides. So there's these three, and then I've heard some in the discussion that I think some new ones that we could add to the list. So the first one, how would the cost sharing structure be established? So would it be similar to the richest MA plan in the state? How would the income-based premiums be developed in a way that ensures affordability? A question about how to ensure that the savings would sufficiently be able to finance the behavioral health benefit in a way that I think folks would like to see. And then a third question about the administrative implications for the state managing the program. And then I'll just call out the other ones that I've heard in the discussion. The first one was basically Chuck's question about people coming off traditional Medicare, kind of if they wanted to go back, you know, what would that look like? Would there still be open enrollment? Would we need to pass legislation to make this happen? Probably, but that would need to be figured out. And then just maybe adding to what Deborah had said before, that while this is clear about the behavioral health, this would be an improved behavioral health benefit, there might be a question about what would that look like, or how do we make sure that it looks the way that would be desirable to those behavioral health folks who have been advocating for this? What does that actually look like? So those are some that I've heard.
Can I just add one to the mix, not to be answered now, but it goes along with that third section, which is the state's going to need to establish sufficient claims reserve. And I think that's something that's going to have to be funded and worked out.
Yep.
Yeah, the state requires, or the Fed, CMS requires a tangible net equity calculation.
Yeah.
That would have to be satisfied.
A small, easy option in this third point is credentialing. There occasionally surfaces in Oregon amongst physicians and other providers a common hospital and clinical credentialing system, so that a licensed provider comes to the state, wants to work at a hospital. Each hospital has their own credentialing process. This is duplicative. It is expensive. It's time consuming. And nobody does it because it's the right thing to do. The hospital do it because that's the way they've always done it. If we can propose that the state takes over credentialing And you can be sure if you're a hospital that if somebody comes to you with a state credential, it's at least as vigorous as your hospital would do. We would have buy-in from a lot of interest groups.
The only issue there is indemnification of the hospitals. The credentialing process by a hospital is a risk management activity. And there would be certainly a request that hospitals receive indemnification should the state take that over.
And I think under those circumstances, that would be reasonable, right? Liability's got to land somewhere.
And of course, a common credentialing program for the state means that the individual hospitals and clinics no longer have to keep a certain proportion of their reserves. So you could see how the state would charge for this process, one of these compulsory payments to collect some of what's already out there in terms of claims reserves. But Chad, you make an excellent point that whenever we talk about change of provider responsibility under a different payment system, there's going to be this long trail of trial attorneys who are going to be sniffing at the droppings, trying to find out where the money's going. All due apologies to the JDs here.
And just to throw in there that I believe OHA had tried to implement a common credentialing program a few years ago, and it was really, really challenging and ended up getting pulled back for a multitude of reasons. So I think such a thing would be definitely a challenge and pretty complicated to implement, but making note of that for sure.
Sarah, if I could, this is John. I'm going to take off. I'll be back. I just want to, for the record, say I like all of these smaller scale options. I think they all could contribute to the cause, and I'm sorry to miss this discussion, but I'll be back.
Thanks, John. So Laura, let's go back to the beginning actually, and we'll do Bruce's, and then we'll go to the other one.
Exactly. And we'll try and, I just want to be certain we have time to go through those other options. So I think we've got maybe about another 15 minutes for this.
Yeah, we're doing pretty good on time. Yeah, so again, this was just the summary of what has been talked about already, that this would be a 1332 waiver to reform the individual market, to have a standardized benefit package, to make it more affordable, no copays and deductibles. The premiums would remain income-based, but make those more affordable. There would be a state-run global budget that would have a growth cap tied to the benchmark. And there, yeah, one tier, one benefit package. So the primary goals that we identified here were three. One, to reduce the uninsured. So this would allow folks who are uninsured to afford to come into the individual market. The second, to strengthen coverage for the underinsured. So creating a better benefit package at a more affordable price for folks who might be in it now, but have, a $5,000 deductible for minimal coverage. And then the third, similar to John's idea, would be to be able to test some of these single payer concepts. So to create an on-ramp to single payer, and those elements that were brought out of last discussion were testing the political feasibility and the will to do this, to be able to successfully negotiate a 1332 waiver, and then to achieve those administrative savings.
And I would add to that, create a common benefit package and the global budget piece.
Great.
In that individual market. I mean, that's really what moves us forward towards single payer, is the common benefit and the global budget.
Bruce, would you envision OHA doing this as well?
Well, when we've talked about this, I think there's a crossroads here. I think that we've been talking about this as an idea that would, I think, more look like the Medicaid model, whereby OHA would, set the budget, the benefit package, and then contract with plans to do that. We didn't, when we talked about this, we didn't really talk about it as being totally run by OHA. I mean, I think that's certainly a possibility and could be sort of to be determined whether to, obviously there's political considerations in moving the individual market away from any of the commercial carriers, and, something to be considered. There's nothing in here that would preclude that.
I'd like to mention, Nipper, if we can go back, the very bottom, it says achieve administrative savings. We should keep in mind that the administrative savings are the way that single payer works. If single payer does not achieve administrative savings, then we are not providing better care to more people for less money. There are three primary ways that single payer reduces administrative costs. One is it reduces the cost of billing for the providers and for the payer. It secondly reduces drug costs by having a single negotiated purchase plan. A lesser but still significant savings that we should remember is eliminating medical underwriting, which is the cost to the administrator to determine the individual risk of every participant. This will come into play if we ever see another discussion about co-pays, deductibles, or premiums that are based on the individual's ability to pay. Once we implement, we don't want to implement that because it cuts into administrative savings and it compromises the chances of this single payer test succeeding.
Actually, Sam, that's great because you anticipated the next slide.
Anytime.
You were right on, because that's what we had. That's actually what we had talked about at the last meeting, was that the administrative savings would be, achieved through the common benefit. We talked about common billing, common formulary, and then while not totally an administrative saving, having a global budget cap is another way to that's prudent and allows for reasonable growth, creates another way for savings.
Okay, so there were a lot of questions identified at the last meeting. What will the relationship be with the small group market? How does the plan help further the goal of disconnecting employment from insurance? Those two kind of were really related to each other, obviously. Would the standardization of benefits eliminate, or how much would it reduce, variability in cost sharing? We had a discussion about the common formulary. I know John raised some concerns about how achievable a common formulary was, and so how to engage the drug companies in a way that would allow that to happen. We talked about to what extent this concept might inform the public option study that if HB 2010 passes. And then to the administrative savings point, how savings could be maximized, given that there would be, the state would start collecting premiums, and that this may reduce billing, and administrative. This may reduce some administrative pieces for the carriers, but they're still going to have these admin functions in their other lines of business. So just trying to maximize those administrative savings given those two pieces. Are there other questions that folks have that we want to make sure we document here?
I'm good. Chad, you're on mute.
Sorry, I think the question about decentralization versus centralization is probably one that should be put
Yeah.
in the list because it will need to get resolved and for clarity purposes. And to Sam's point, the yield will be greater with one than the other probably.
Yeah, good point.
Yeah, good point.
I mean, just take the drug purchasing as a case in point. I'm seeing a lot of similarities in these things with what we talked about with the Medicare Advantage. It's kind of interesting.
Yeah, I was thinking the same thing. And, clearly these are not mutually exclusive. And actually they could, they could administratively come forward in very similar ways,
Right.
with the same benefit package, et cetera.
Right. Just a question, maybe not the right time, but are we going to put forward sort of a menu that the legislature is going to sort of choose off of the menu? Is that the way this is going to work?
Yeah, we'll talk a little bit about that more in the last agenda item, but I think it's how we want to present this work.
Okay. And this third one got duplicated. These were a couple of other questions from earlier, helping to make sure that cost growth, that cost growth cap is achievable and isn't eaten up by, a certain area like provider reimbursement or pharmacy costs. And then thinking about the income-based premium structure and how that would compare to the current structure. Anything else that people feel like they want to talk about with regards to this concept?
I'm good.
Me too.
Okay. So we will transition now to the other three options that we heard about really quickly at the beginning of the intermediate strategies, I think the first or second meeting, and have a chance to return to those in a little bit more detail and have a little more conversation about them now. So I think first up is the CCO consolidation. So Chad, do you want to just remind everybody, talk through this idea a little bit?
Chad,
You're
you're
still-
muted.
I don't know why I keep doing that. It's a pretty simple idea. Basically, the idea is to move in light of a migration to a single payer at some point, is to move into a single CCO per market and to develop a mechanism to have a single CCO in each market and thus reduce some administrative costs, and maybe as part and parcel of that, maybe to extract some reduction in administrative costs as part of a successful sort of bidding process. But it's basically a winnowing down process of the CCOs. So it's a pretty simple idea.
Great. The next slide shows some of the questions and issues that have been raised in the past, how this might impact provider reimbursement. If a provider is a market that has a lot of CCOs, providers might prefer this or they might oppose it. Sort of what would the stance of providers be? Potentially this might enhance a focus on services that support SDOH, depending on the region. The point was made that, this isn't just about reducing administrative costs, that it, kind of captures opportunities by a single CCO that may not be able to be captured with a market with multiple ones. And then there was a question about sort of the goals of this regarding coverage. So thinking about some of the, I think this was earlier on when the group was really talking about, are these ideas to be focused on those who don't have insurance, that's 6%, or those who are underinsured, and thinking about the relationship between this idea and potentially those goals.
If I could just kind of respond, it certainly in the latter wasn't my thought that we would sort of get into that much. It was really more a matter of just narrowing it down, narrowing down the players. That's not to say it couldn't engage in those issues, but right now that wasn't, when I first thought this through, that wasn't my thought.
And talk to me a little bit, Chad, about the savings. You see the savings at the CCO level, so that if we went to this and said, okay, make proposals, the CCOs making a proposal to be the sole one for an area now covered by multiple would show a lower cost?
Well, there's an economy of scale issue, Chuck, I think. So right now we have several providers. Now, theoretically, maybe it's hard to see that economy of scale, but I would envision that if they have the entire market, that proportionally their overhead costs should be somewhat less. Now, how to get at that is another question.
Chad, I have another question about one CCO per region. The flip side of that is every region in Oregon, no matter where anybody lives, they're under the jurisdiction of a CCO. Maybe if we do that, like congressional districts in Oregon, there may be the question of which CCO has saddled itself with the most expensive patients because they're either rural, they're Native American, they're immigrant communities. And I wonder if we're heading toward a legislatively determined division of CCO boundaries without giving CCOs the discretion of where do you want to stop in terms of who you include.
Yeah, the question I have that I don't have the answer to, Sam, is, I'm in Central Oregon. We have a single CCO and a single, carrier partner, and take all risk associated with it. What I don't know is in those markets that have several CCOs, how do they allocate? How does this work? I mean, do people move between them? Do they allocate the Medicaid market between the CCOs? I don't know how that works. Somebody else would have to answer that one.
Bruce, do you have information about any overlap in CCOs now? Or if there are people who fall outside of any CCO?
No, well, to the second piece, there's CCO coverage for every zip code in the state. There's no part of the state that doesn't have a CCO. And what the state has done is put out areas for bid, zip code areas, that when the contracts are awarded, CCOs are able to bid on, put in an RFP for coverage in certain zip code areas. That's why you see some CCOs in more than one zip code, more than one area.
Thank you.
So I have two other kind of things that I think should be considered. One is in doing this, do we memorialize the current regions? And would that make it difficult to redefine the regions in some other manner later? So, that would be one question, a policy question, or sort of a concern that might come up. The other one is, would a CCO be permitted to operate in several areas of the state, or theoretically, in other words, an operator of a CCO, would they be permitted? I think now Pacific Source may be in several CCOs, and would that continue to be permitted?
Yeah, so I think we should actually make a statement about your first question that, we've talked for regions with the single payer, there being, how it's a hard decision to make, but we see it as being fewer people, I think, are sort of in agreement, fewer than we now have as far as regions, and maybe designed differently with different criteria. And so I think we should be clear that this is not a test of the regions. It's a test of single CCO per region. And just be clear that this is not setting precedent for who. And then as far as whether an entity could be the CCO for more than one region, I tend to think that's fine.
I think that's happening now. But that has to do with the underwriter, Pacific Source, for example. In Central Oregon, the CCO is distinct from the carrier, and that structurally they're separate.
Yeah, I guess I would believe that it's possible, and that I would defer to things like outcomes and just how well they're doing, how connected to the communities they are, as to being the determining factor rather than could they. I think I would ask, should they, right?
I would agree.
Yep. Looks like we lost Bruce.
Where are we without our leader?
And Sarah's good hand.
I have so much faith in all of
Anarchy.
you. Here he is.
Absolute anarchy.
The next slide was just, and this is just how the structure for all of them was just sort of, is there anything that we missed, either clarifications for today or questions that would be needed for follow-up? I have heard several questions named potentially for follow-up that we can add to the list. Are there other things that people want to discuss or ask about with respect to this concept?
The questions of process, I don't know if there was any question about process in terms of how that would occur, how the migration from several to one would happen, but there may be you might want to have an item on that.
And I think that would, the CCOs have 5-year contracts. It would likely, easiest way for that to happen would be at contract renewal.
Yeah, and I don't think I have a question rather than a comment, that it would be my expectation of any of these models to try to parallel as many of the deliverables in 770 as possible, so that it is really a bridge, right? It shouldn't be more of what they're doing now. They, in addition to getting a better market share, they should be transitioning fully in terms of their capacity, their outreach, to what the ultimate goal is.
And embrace the values that have been proposed, right?
Do you feel ready to move on to the next one? Yes, okay.
And my apologies, there was construction outside my window. I needed to change locales.
We thought you were tapping your foot there, Bruce.
So the next one is the VBP sort of expansion and community engagement. Chad, do you want to just quickly go through this one? Not quick,
Yeah.
take your time.
The idea with this is that, as you know, during the course of all of our meetings, there's been a lot of animated discussion around the idea of value-based payment. And whether value-based payment is good for whomever, for the providers, for the patients, for the community, for whomever. And, you know, my idea was that we take this as an opportunity to sort of move value-based payment. My idea was sort of move it on its head and make the notion of value be defined by the community and the people for whom we're trying to deliver value, as opposed to value by an insurance carrier, for example, which could be a financial value. So the idea was to kind of flip this over and redefine value-based payments so it ceases becoming a you know, a problem, if you will, and we move it back into a way that it sort of drives the values of what we're trying to achieve, I guess.
Okay, great. Thanks, Chad. Next slide.
Excuse me, could I make a comment about what Chad just said on value-based payment? There's two different concepts that we need to distinguish. One set of value-based payments is based on outcomes, either to the individual payment or to the community. The other is based on the actual kind of care that is considered standard. In the first case, that has been shown to be a disaster. Where we pay providers based on outcomes, we encourage providers to avoid sick patients or sick communities. There is no evidence that value-based payment that said, if your patients do better, we'll pay you more, results in better communities. On the other hand, there are procedures within clinics, within how we treat people, that have been shown in populations to succeed. For example, sterilization for central lines has eliminated, for the most part, hospital-based infections from central lines. That is mostly good, but the danger of that kind of value-based payment is we institutionalize the standard of care and it never changes. And then we discover that we have institutionalized the best care from 1995. So we need to accommodate these kinds of considerations when we talk about value-based care. Otherwise, we might be talking about one kind and the objector will be talking about another.
Sam, I think you're quite right. But in addition to all of those things, we need to examine what does the user of the services define as value? Because I fear that we've really spent precious little time on what the end user determines is valuable.
I'm reminded of something my chief of service told me about resident education, and I began giving him feedback about what residents want. He said, if you want to learn ornithology, you don't talk to the birds. What this might mean for us is what individual patients considered to be good care might in fact be bedside manner, something based in the faith of the provider or the institution. I have a hard time when we turn over quality assurance to patients. It sounds heartless. It sounds dismissive. And perhaps it is, but I just don't see that working to provide the kind of efficient healthcare system we want.
Well, Sam, what I would say is I would say that there's a sweet spot there, because I think your points are all well taken. And on the intricacies of clinical care, clearly clinicians and people that are aware of outcomes and what the data is should rule the day. On the other hand, there are elements of value which we disregard completely as it pertains to the end user, and that must somehow be considered as well for the end user to embrace it as valuable.
You make a good point, Chad. We should say, we should answer the question of value to whom. This particular process is valuable to patients in terms of whether they feel like they've gotten good care. This particular item is of value to the community because we can demonstrate that the social determinants of health have improved. This is of value to the providers because they're doing more with less money.
Right, but I don't think in value-based payment, this dialogue has ever occurred, Sam. That's kind of my feeling about it.
I agree, it should.
Yeah, so Sam, what do I do with what you just said? All right, I'm gonna try to, so yes, it did sound a little harsh, and I appreciate you acknowledging that. And I do appreciate the sort of back and forth that's gone here. I don't think it's ever been examined, right? And what I can honestly say when at least the way I assess healthcare and the current systems and its failures is that we have objectified patients, right? Care to what end? And if it's simply care to resolve an issue, right? We provide a surgery to, improve a defect of some sort. That's one thing, but has my quality of life as a result of you improving the defect really changed for me, the person you just, perform surgery on? Those are two completely different questions. You can get the surgery completely right, but I don't feel any better about either the process, my experience, or how I continue to live, post-surgery. So I don't think, it's good to have, things we can quantify to say, yes, objectively speaking, this is better. But we are talking about care for humans, and they are so much more complex than did we do a good job on paper? Did we document, what we needed to document to say it was a success to us and to our system and to our books? We're supposed to be improving the lives of actual people. And a lot of times those people don't really care about the spreadsheets or all of those other things that really look like we're doing a good job, because if that wasn't so, then every patient who's had care, objectively speaking, would give a good rating on the quality of care we've given it, particularly if we compare it historically to all the improvements we've made in the systems over time. I think the other piece of that is that as a BIPOC person, thinking about the experimentation that resulted in some of these technologies, it wasn't, with a consideration for BIPOC folks as they were being created. And I think some of that acknowledgement is born in what's here to say, I want to stop being objectified, and I really want you to focus on me as a whole experienced person and not just an object that's a means to an end. So I think when I say, value to whom, it's with all of those considerations at the very personal and emotional level that we're not going to see in a report, that's usually quantitative and not qualitative.
Deborah, I'm as uncomfortable listening to what I just said as you are. Here's an example of what puts me on edge. At a hospital where I used to work that shall not be named, there was a chair of orthopedic surgery who shall not be named, who was universally acknowledged at the hospital to have absolutely the worst results of total knee replacements. We knew that every one of those patients was going to be back for a revision. He was exceptionally popular with patients because he was the chair and he worked the network. There would be people who would come to the hospital and say, I don't want anybody to work on me, but this guy because he's the chair. That's my fear that I'm done.
Well, hold on. I don't think anyone has been talking about any of this as being mutually exclusive.
Right.
I think that a good system actually is one that blends the values and expertise of quality improvement experts and data people along with the values of individuals and community, and actually comes up with something that's really good. And I think what Chad was saying and what Deborah was saying is that our quote value-based systems to date have really been more based on the financial value to providers or to carriers and not to individuals and community. And we need to restore that balance. And I think that's a great idea. My question for Chad and for all of us is, do we need to take this one step further in terms of, expanding the notion of value-based payment to include community input is great, but it's only great if then payers all use the same system in a community. And so do we take this one step further, which I think gets at to what we've been talking about in the other ideas of administrative simplification, is having one standard for quality and value and measurement so that we have some consistency and we don't have the administrative duplication of 6 different ways we measure quality for diabetes.
I think it's a good idea. I mean, as a starting point, you could do it through OHA and the CCOs. So that could be sort of a learning place, but all of these other projects that we've talked about here, all theoretically, if implemented, could be implemented with this sort of construct in place. I don't know if by state fiat, you could sort of roll this out and say, thou shalt, do it this way. I don't know.
Well, we've been trying to do that in this state, at least with those lines of business that the state purchases for, Medicaid, public employees, and educators. And it's been a slow process to sort of create that common set of standards across all of those lines of business.
My sort of Pollyanna of this whole thing is that you sort of, that we have this sort of inexorable role of OHA, that it sort of goes from Medicaid into Medicare Advantage into the individual market and into the single payer, that is sort of an inexorable sort of expansion of the role of the state in this, and that this notion of value-based payment goes along for the ride, kind of, but that maybe takes too long. I don't know.
So maybe we could just move on to the next slide, which just brings up some of the other points that were identified, which I think is somewhat similar to the conversation that has just happened. But I do want to just highlight the first one, which was about the CCO consumer advisor, the role of the CCO consumer advisory committees, and that this was highlighted as something that might be a place for this to happen. And then, Chad, I don't know if you have comments on these. And then the other thing is just other questions that folks might want to identify that they would, that we would need to work out in order to move this idea forward.
Well, I think the questions are good, but I think the thing that was just raised regarding how you do anything with this idea is an important one. And I guess I haven't thought that through. So
Yeah.
I
we'll
I guess I would
definitely
say the
note that.
CCOs, but I think the questions are fine.
Thing it in theory, right? So, yeah, I don't know exactly how we do it, but I think it's worth, as long as we're innovating and trying to get to the next level, it's definitely worth the effort.
We could add maybe a piece there about, implementation needs to be determined.
That's on all of them.
I agree.
Okay, are there any other pieces that folks want to ask about or comment on with regard to this idea before we move on to Chuck's? All right, hearing none. Let's go on to our last idea. And Chuck, I know that you'd had a few additional thoughts on this in the email, but other potential directions to go. So, this slide shows the original.
Initial idea, yeah.
Yeah, and then the next one. So I'll just let you take it away.
So, I don't think we have good data. I tried to pull it from that Kaiser report that one expert told us to read, and was having a hard time doing it on how much are businesses spending on insurance, how much are their employees having to spend, they vary on whether they pick up family coverage and percentage of all that. What's the percent of payroll? I think using averages necessarily is that we've been getting out of statistics isn't necessarily good. And by using FTE information, you'd be able to deal with partial year coverage. And we also don't have good data on the self-insured companies. And so it just seems like they have these expenditures that they're ordinary business expenses that are calculated for when they file their taxes. But it would be nice to have them sort of delineate them out on some schedule so that those of us trying to figure out how do we ultimately pick up the cost of employer provided coverage when they start switching to our state plan, we have a better sense of what that is, and also a better sense of, in talking about the finances of our single payer payroll tax or whatever, whether have better numbers to be able to compare those finance options too. So. And then I thought, there are just other, other data like the employee premium side of it. I don't know if employers would have that. They should. That's not listed in their expenses, of course, but it's certainly data they have. And then from just experience I've had recently, personally, it's sort of like it just blows me away that I tried to find out the cost I would have to pay for an MRI, and the range of numbers I got. And if the insurance company says talk to the hospital, and the provider says talk to the insurance company, ultimately I was told, well, this is what we will bill the insurance company, but this is what the insurance company will pay us, which is less than that, and you'll pay 20% of that lesser figure. And I just sort of feel like, well, someone today, I think we would benefit, assuming that, the decision by voters to approve all this is down the line, that people would benefit if today they learned what the costs are, what's getting paid by their insurance company, more clearly than you're getting out of the EO statements that clog your mail. What's getting paid for the drugs and whatnot. So it's, you know, it's different than the first one. You know, I think that I think getting at employer provided more data for the employer provided coverage is helpful, but I just thought, it seems like there's a bunch of other data stuff that we could get, but maybe, you know, the problem with this one is under a single payer, people maybe won't need to know, or maybe they should know what the cost is, so they'll not be upset with the tax they're paying, or a variety of taxes they're paying.
Chuck, a little background on what you just said. Nobody in Europe or a Pacific Rim country can tell you how much their procedure costs. And it's not a tragedy because they don't need to know. In the United States, we need to know because we're going to end up, even if we have insurance, paying for it. And ideally, our single payer system will eliminate the need to know. You will get your procedure if you need it. You don't, and it's strictly academic how much it costs. You do bring up a very good point, which is reminding people, even in a single payer system, how much value they are getting for the massive amounts of taxes they're paying for healthcare. So there is, I think that point might be best expressed in something other than immediate transparency of procedures. But we do need to continuously remind people of what they're getting for their tax dollars.
Yeah, I
Because
think
you know,
that-
go ahead, Bruce.
No, go ahead.
No, you go, Bruce.
I mean, I just want to pick up on Sam's point. I thought that, you know, the reason for these are intermediate strategies to bring us towards single payer. I thought what was particularly intriguing and useful and necessary about this idea is exactly what Sam was alluding to, that it would get us a lot more information about what is currently being paid. And that would help demonstrate to people the value and help people understand where all the dollars go. You know, I don't think, for instance, people even understand today that, you know, their private insurance is being subsidized by federal dollars because of tax credits that their employers get. It's a very complicated system. And I think that one of the ways that, you know, one of the vulnerabilities of a single payer, as we've talked about, is the price tag. And part of that is because we're unable to demonstrate all the other ways and all the other costs that currently are being paid within the system. So that's why I've always thought this is really important.
Yeah, that's.
Yeah, no, I totally agree with this. You know, I think that once we expose through transparency, you know, a lot of different data sets and data points, then not only is the expense, you know, to the consumer exposed, but also the profits are exposed, right? And the variability, for example, for the same procedure based on where you're getting the care. So I think there's a ton of value here. And anytime you are about to pull back the curtain, again, this is another space where it seems on paper it makes sense, where there will be a ton of pushback and contention for the status quo because of those reasons.
Well, and also sort of debate and obfuscation. You know, I mean, one of the problems with this is that, you know, I've spent 30 years of my career basically in the weeds of this, and it is very difficult to explain, particularly with the arcane rules that Medicare has and so forth. I mean, I think if you can move it over to the single payer, that's one thing, but in between, boy, it is hard to explain. And it's very easy for third parties to obfuscate and put mud in there and stir it up nicely. And
Yeah, and so I am admittedly confused on, you know, is the burden on the provider, or is it on, you know, today, is it on the insurance company, right? To be more clear. That was one of my frustrations with my MRI example. I just like, who can tell me the simple answer of what this is going to cost? And I know from my direct care provider who doesn't deal with insurance companies, he said, this is my dollar amount. And it was a fraction of what the insurance company was going to pay for the MRI. And the insurance company couldn't believe the number. They said, they can't do that. I said, no, call Salem Radiology. They have a deal with doctors like mine. It's $590, and you're telling me it's $3,000. Or you're going to bill for $4,000 and pay $3,000, right? And the insurance company doesn't tell you that. The provider is who tells you. So it's sort of.
I can't tell you the number of hospital bills that have come out from hospitals I've run, which have been $30,000 or $40,000 or $50,000 bills, and you try to explain to somebody that you're actually getting paid $2,495 for that. And it's just this whole thing is so arcane. But the arcane nature of it makes it very difficult to explain. It's almost better to go across and put blinders on and don't look back.
Right, but Sam's point that people knowing what the value is because they're going to be paying taxes, I think is.
Well, you can talk about per capita cost. So you can, you can synthesize it all down to per resident. That's not particularly complicated if the data is available. But then cost borne by whom is where the rub is. I mean, we haven't even been able to get that for our 770 work.
Great.
Exactly.
And I think about it's like, so I'm in that age group where you every so many years get a colonoscopy. Well, I'd love to know how much I'm paying when I'm sitting there with my friend and say who's telling me he's getting one next week. He can tell me how much he's paying with his insurance, and what the doc's getting and the hospital or whatnot. And you can't do that today, which is just bizarre to me. So.
Oh, Ed's here. Ed, do you have your hand raised?
Ed, welcome back.
Hi, thanks. Literally, I walked in just a few minutes ago, right as you started this topic, so I apologize for missing that.
He's still walking.
Yeah, I've been sitting for 6 hours, so I need to be walking. So here's my question. What is this? I completely agree with what's been said, the transparency, the need for the data. I think this is really superb. What would this actually look like? I missed maybe an opening that said, is this a proposal for a study to find the best data points, the best sources? Is this an entity that would come in? What does this kind of look like? Is this our current infrastructure, maybe the OHA, or who would do something like this? Because I think that this is a real credible idea. I just am trying to operationalize it in my head. So Chuck, can you think of what this would look like?
So the first part on the tax thing, it's just, I think, a form that DOR would have businesses have to fill out. But for this, I just sort of see it as when you call up for your appointment, the provider will have to tell you, this is what we're gonna charge. And and maybe when you show up, you get a piece of paper that says, this is what we're going to charge. This is what your insurance company is going to pay. And this is what you're going to pay. This is what it is when you have that appointment.
Yeah, I wish it were that straightforward. I mean, there are providers on who I don't think would be able to answer those questions.
Well, that's
ourselves.
Right. And so, I mean, so I think they'd have to come up with the system for that. I mean, that what I was told is by my insurance company is you have to talk to the providers, and so I mean, I just think.
Chuck, can I ask you a question about this? I worry that this might not advance our 770 goals. And I wonder if you could talk about that a little bit.
Yeah, I think it advances them only sort of tangentially. I think it gives people information that they can use for comparing against what they're going to be asked to pay in taxes. To the extent it gets implemented before that, right? And then I think Sam's point that once you're in the system, you're sort of seeing the value you get. That would be the advancing. So I agree. It's both. Both of them are somewhat tangential.
It sort of feels like a lot of mud. And I just worry that that opens up opportunities for sort of manipulation as well.
Yeah, I think the first part about doing it for what are employers paying, getting the details of that data that now is aggregated in a general, these are the costs of business, I think isn't problematic, but I think this one has
Yeah.
more problems.
Yeah, I want to make a distinction between the payments by employers, et cetera, which I think would be important towards advancing the 770 goal, versus the individual procedure need to know. I'm not sure how that advances what we're doing as well. I would agree.
So maybe the idea is narrow it to the employer piece of it.
That's fine. That's fine with that. I think we should just all, to Sam's point, I think we should be, and to mine, I think we should be thinking about how are we going to get people to see the value of the new revenues that we're asking them to contribute a different way, and to continue to support it down the line. So.
Okay.
I'm fine with dropping it.
Okay, so we'll kind of go back to that original concept. And, we've captured the discussion here. Anything else? Any last thoughts or questions or comments that folks want to add to this before we move to our next agenda item?
Next.
All right.
Okay. So next, I thought it would just be important for us to spend a few minutes talking about how we take this work we've done in this group and move it forward to the task force, et cetera. At our meeting we're meeting end of May, but then we have 2 meetings in June. And at our June 9th meeting, we've got 45 minutes to review the work that we've done, all these ideas, and discuss them with the task force and get the entire task force input, et cetera. Just as a reminder, legislators gave clear direction that really sparked this group, which was, give them some ideas that provide a bridge to long-term goals of 770, build on Oregon's history of innovation, and, include those ideas in the June 30th deliverable. That's what they asked for. So what we thought, we would do is, try and provide, a brief overview of each of these ideas. I think that's going to be a little challenging. We've got 5 ideas, and to both present them and get questions and answers in 45 minutes will take some discipline on our parts, but I think we can do that. And then, I think to have a discussion with the task force about how to include these ideas. I think, and that's what I'd like to get some ideas right now about that. My sense has been, and this gets at a point Chad raised earlier, that, I think we've got 5 very solid ideas. In some ways they're different. In some ways they're all very complementary. And that we in essence, present them all five, that we're not going to prioritize or vote, but that these would be ideas that, here are five ideas that we've come up with for your consideration. I think what's probably more important is that, today get some, I think, input on how to frame that. Because I think there's been, some concern that these ideas could be seen as competing with or in lieu of single payer. And I think that based on all the discussions we've had, that's clearly not the case. These have all been crafted as ways to move us forward towards single payer and would be, appropriate steps. But I think some discussion about how best to frame that would be really important. So let me stop there, and really would be interested in everybody's thoughts and ideas about that.
Am I muted?
You're good. We hear you.
Okay. Well, one of the things I think we should present is we need to, in each case, explain the bridge. So we need to explain, we are here now, we want to get there, this gets us a step. I think we need to be very crisp about the way that each of these forms a bridge to the 770 outcome.
Great point. And I think we've done, we spent a fair amount of time, I think, doing that and talking about that.
Yeah.
With the two larger ideas. I think we've got to probably get, Sarah and Laurel to spend a little bit of time putting a few bullet points together for each of those other three ideas, in the same way that you so nicely did for the first two.
I agree with Chad. It would be really ironic if one of these suggestions were implemented and worked well, and the legislature used that as an excuse to say, we've got something that's working well, let's not do anything more for a couple decades. We do need to, as Chad said, say, these are no substitutes for single payer. Do not walk away from this.
We will get an idea of whether there's any preparation or any desire to do any heavy lifting at all by putting these forward, because every one of these involves some significant heavy lifting, and that will be revealing in itself.
We could say to the legislature, if you don't have the chutzpah to implement one of these, just send the rest of us home. Because if you don't like this, you're going to hate the single payer program. Just kidding. I don't think we should say that, because some people will take us up on that option.
Well, I guess back to the point of the near-term question, which is how to get this through the full task force. And I think there that we need to be very clear how each of this advances the goal that we're trying to do in the task force, and just kind of crisply knock through each of those, explain where we're trying to get, and this is a step in that direction. And because otherwise we could get mired into a long conversation and not even get through all of these.
So maybe what's also needed though to do that is so what's the timeline for the full task force report and implementation, right? And sort of lay out, it would take this many legislative sessions to adopt it. These things would have to go to the voters before waiver approvals and whatnot. These things would be afterwards, and sort of show the timeline for that and say, this stuff, here's the timeline for this. The 2022 legislature could do this legislation, and then blah, 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 and show that it can proceed without messing up that other timeline.
Well, that
Help the other timeline.
that does beg articulating what needs to occur. And I don't know if we, in part of this, we need to articulate the steps that need to occur, i.e. waiver legislation, regulatory changes, what needs to occur, or if that all happens later. I don't know what our job is in that regard.
Yeah, I like the timeline suggestion. And I also know that for a lot of the advocates who are, a part of the task force, none of that is going to resonate. Like, they want this done yesterday. And so even the realism that we're still talking 5 or more years out is not going to sit well with them. So I just want us to be really comfortable that whatever timeline we roll out as being reasonable, right? From just systemic change is going to make some folks really uncomfortable and feel like we're not really approaching this in earnest. And that's not the case, but that's what it will feel like from folks who are just eager to get this thing done and not seeing all the moving pieces and all the bureaucracy that has to happen. So I just want to posit that.
Let's go to Ed, and then John has his hand up as well.
Yeah, thanks, Bruce. So I remember thinking about this and articulating out loud that we would be having this very conversation about how to bring these intermediate strategies to the task force. And it so far has played out exactly as I thought. And remembering that this is a public meeting and that all of our stakeholders from HCA and other people who are very much supportive of 770 are watching us right now. And so this very conversation is a necessary conversation to be having publicly. And to that end, I think it's, number one, reassuring that we are articulating as a 770 group that these are intermediate steps and that this is not taking our attention or our energy away from 770. And, I agree that a timeline might be the best way for us to build the narrative that we want out there, as long as we are continually referring to this piece of this within the timeline of the overall 770 plan. So I'm in favor of transparency. I am speaking directly to the people who have been speaking to us when they get the chance. They email me, they talk to me, they text me. So I'm talking to them to reassure them that we are doing our level best with the time that we have realistically to put 770 in place. And it's going to take time and it's going to take steps.
Great, thanks, Ed. John?
Yeah, at our last discussion, I think there was some points made about, let's face it, some of these things are going to take 5-6 years to do. And I think I agree with that. But I think if the task force says you asked for these ideas and here they are, the debate is on. I hate to use the word, but the fight is on. Because to get some of these to the point where you could move them to reality is going to take, quite the discussion. And just the discussion itself will put the onus on various parties to declare where are they at with this. Like I'm very interested in where will the providers be with the idea of, a single payer, collaborative, not market-based approach. Which payer groups? Which provider groups will take what side or another? So I think while actually doing it is 5 or 6 years off, getting a very good sense of where the different players are would be 6 to 12 months.
Thanks, John. I want to weigh in for a minute on the timeline. I think actually having a timeline is a great idea. With that said, and looking at the work that we have to get done over the next month, I think that quote unquote implementation timeline is probably something that we'll need to work on during the extension period. And we won't be able to have just yet. And I think we can say that. Other thoughts?
Yeah, and I do think Ed's right about, I think the advocates for this do want it yesterday or think that it can happen fast. I have the sense that some of them think it can happen really fast. And so I think a rough timeline, I guess I would call it, if we're coming out with a report before our life gets extended, I think it could say, we expect the 2022 legislature to do A, the 2023 legislature to do B, that, it would take, this range of months to be able to put together a demonstration application to Medicare, a 1332 waiver to application, whatever it's called, for Medicaid, for ACA, and so to have a really rough timeline that this isn't happening tomorrow.
On the other hand, it will happen at the speed of political advocacy.
That's right.
I mean, and I think that, now maybe I'm going to retract what I said about a timeline is a great idea, because I think what we may want to do is, put both these intermediate strategies and our 770 plan out there, and then it's going to be up to those people who are going to advocate for these to actually move them along. And that becomes actually someone else's job and not ours.
Mm-hmm.
And that if people can move, if someone can get a single payer, our single payer plan passed in a year, God bless them.
Yeah, Bruce, I'm kind of with you. I'm mindful of Tom Sinsek's comment about sort of our job is to lay it on the table and they'll take it from there.
Yeah.
And I think that we haven't really been asked for a timeline, I don't think. And I think we've been asked for sort of content and structure and maybe some steps. I'm worried that a timeline could be actually kind of used against everything. I don't know. I'm just not sure about it myself. But I do think we need to lay out some steps. And these intermediate strategies, it seems to me, are steps.
Bruce, can I just chime in here for a second?
Of course.
So at our last meeting, for the two bigger ideas, we had put together some bullet points around what federal engagement would need to happen and what state engagement would need to happen. And I'm wondering if something like that might hit that sweet spot for, it's not necessarily a timeline, but it does show like some categories of things that would need to happen in order for these to move forward.
Yeah, I think that's a great idea.
Okay, so we can do that kind of for all of them, I think.
Okay, I'm going to try one more time about the timeline thing. With the timeline, the message behind the timeline is momentum, and momentum moving towards 770. I agree that we weren't asked to give a timeline, but we were asked to put something on the table, and we put a lot of work into this. And, I think that we need to control a little bit of the narrative in terms of momentum forward. We know this plan better than anybody else. And I think that we know the steps towards this plan as well. A timeline would start to define what that narrative looks like. Maybe timeline's not quite the right word. And as Chad said, steps. But, nonetheless, I think we need to establish that we are behind momentum moving towards that 770 and that we as a group believe that we understand what the steps look like.
Yeah, and so maybe it's that timeline is probably the wrong word, but maybe it's in describing these steps we be clear about these could happen fairly soon. You know, that we're not talking about multi-year discussions about some of these things, you know.
Yeah, I do like going back to, Sarah's suggestion. I think, Ed, to your point, that if we were to sort of meet out some sort of timeline that established dates or months or years, and they don't occur, then we as a body individually and collectively lose our credibility, right? Because, we're supposed to be folks who think about all this stuff all the time. And I have concerns about folks losing hope if we give them something that is almost a promise, right? That because there's so many factors that are out of our control, that I'm a little bit reluctant to really get in the weeds in terms of establishing milestones. I like this is what has to happen federally and statewide. And then again, there will be processes that have to happen in all those. But, for us to commit to a timeline that none of us know for sure doesn't feel to me like it would do us any favors.
Chad, it looked like you want to say something, but you're on mute.
I do think we need, first, I think this dialogue should occur at the task force level, actually. That's kind of my thought about this. But I do think we need to express some urgency. And we should not be shy about having some sort of expression that now is the time, we need to move, we need to be brave, we need to get going on this. And that we certainly, I think, would have unanimity in the task force about a message like that. And I think we'd be remiss if we didn't do that, at least.
Yeah, and this was not meant to preclude a discussion at the task force. It was meant to help us have that conversation at the task force.
Right.
So this is really good.
Yeah,
Sarah?
Chad, make no mistakes. We're going to have the same discussion. I mean, because we have all moved in the same direction. We're going to be doing this all over again. I just have that feeling.
It only gets better, Ed, though. Hey, Sarah, do we have any public testimony?
I do not believe so. I don't think we've received any ahead of time. Is there anybody here now that wanted to offer testimony?
Great. I just wanted to be certain that we offered that opportunity, and I didn't mean to cut off the discussion if there's anything else that people want to add. I think that was very helpful. Sarah, Laurel, anything on your end?
I don't think so. I think this gave us some good direction. And Bruce and Ed, we can work with you a little bit on what these slides will look like for that task force meeting, kind of taking into account everybody's comments here. I don't have anything else.
Yeah, and just be prepared. We may be asking each of you to present your ideas, but we'll work on that. Anything else that anyone has to bring up today? No. Great meeting. We got through everything we needed to get through. I think we did a really great job. I want to thank everybody. And we'll see everybody May 27th.
Yep.
Fantastic. See everybody then. Take care.
Thanks, everyone.
Hey, Bruce, I sent you something the other day.
I saw that. I was just
Yesterday.
began reading it this morning. I'm gonna get back to you.
Okay.